This is a presentation on blood flow restriction, a scoping and review of the current literature as of August 2018. The objectives that will be covered will be the definition of blood flow restriction, the effectiveness of BFR and local systemic physiology, the mechanisms of BFR, safety and side effects, the practical and clinical implications of this modality. So beginning with the history, it was developed in Japan in the 1960s by a gentleman named Sato. It was known as Katsu training. It has been performed in Japan predominantly ever since. Since 2008, it's only recently become prevalent within the United States, particularly with the equipment and its accessibility. The definition of blood flow restriction training is training with a tourniquet-style cuff on the proximal limbs, either upper and or lower extremities. It can be performed in addition to no exercise, resistance training, and or aerobic or anaerobic training. The pressure that occludes the venous flow yet allows arterial inflow, and the intensity of the blood flow restriction is related to the amount of occlusion that is occurring to the arterial inflow, usually between 50% and 80% occlusion of the arterial flow with complete occlusion in the venous system. Okay, so here's a brief video to give you an idea of what it looks like in the clinical setting.
Okay, so this is a video to give you an introduction to blood flow restriction. So there's 4 different types of cuff. The green one and the red one are smaller and more diameter, so they're usually used for the upper extremity. You have the dark blue and the yellow, both of them different diameters depending on the patient. Right? And then if you come in closer, what you can see is that, at least with this particular model, that depending on the color of the cuff and the size, that they give you recommendations as far as like the initial pressures that are to be used. And then depending on the patient's response, low fatigue, mild fatigue, severe fatigue, etc., you can change the amount of pressure accordingly between the sessions. Okay? And then I'm going to have my assistant John here go ahead and demonstrate the blue cuff around my thigh.
Go ahead and pull it as high as you can. Pull it as high as you can, great. And I want you to tighten it as tight as you can, without putting any pressure on this leg. So most weight on your left. Right. Now, I'm going to go ahead and release it.
Go ahead and zoom into the pressure so you can kind of see how this works.
How much pressure would you want?
So if we're starting on the blue, starting at 250 to 300. Now optimally, we would know what my arterial pressure is going through my limb, and we want it to be between 60 and 80% occlusion relative to whatever it is for the person. All right, so now that the cuff is on, strapped up, pressurized, I can then go through whatever exercises are otherwise intended. The cuff, again, the duration and the intensity of the exercise that is so chosen by the therapist is depending on the material in discussion.
Okay, so that gives you a general overview. The next section that we'll get into is the effectiveness of blood flow restriction and some of the blood flow restriction in combination with exercise leads to hypertrophic adaptations with much lower intensities, typically between 20 and 30% of one's 1 rep max. This is significantly less than what is traditional. Usually you need a stimulus of greater than 65% of one's 1 RM or 1 rep max in order to actually get a strength training stimulus to the muscle. Low intensity BFR hypertrophy is equal to moderate to high intensity hypertrophy or strength training. It is not clear as of this time if muscle hypertrophy can be optimized by blood flow restriction plus increased external loads, or if the ceiling of maximal hypertrophy is achieved with low to moderate loads. And as we get into the discussion about safety and recommendations, we can see that the higher external loads typically will increase one's hemodynamics, blood pressure, heart rate, cardiac output, etc., to potentially questionable levels. So using the low intensity has not only shown to be sufficient for increasing strength and hypertrophy, etc., but also safe with when done on healthy individuals with good hemodynamics at baseline. Okay, so starting off with a larger picture idea of what the effectiveness of blood flow restriction training is. This is a meta-analysis that was done in 2011 by Jeremy Lenicky and company, and so they are the University of Oklahoma and have done a great amount of the research that has come out since about 2008. So 11 studies were included within. So this first table gives you a good idea of the patient population as well as the exercise mode and intensity that was utilized. So majority of these studies are less than 25 or young individuals. Majority of them are males. Majority of them are either recreationally active or athletes. Only 2 of the studies were untrained individuals. The different exercise modes, you can see that it was everything from cycling and treadmill walking to squat and knee extension. So aerobic as well as strength training based exercise. When you're looking at the intensities, they varied between 20 and 30% of one's 1 RM, and then there's also variation within the aerobic studies looking from 50 meters per minute all the way up to 67 meters per minute. And then a certain percentage of VO2 max could also be standardized. The frequency varied considerably, as well as did the length of training. There is also variation within the protocols as far as the sets and rep schemes. We'll get more into the specific parameters and optimal parameters as far as sets, reps, volumes, etc. in slides to come. Here are the metrics as far as what was used to determine muscle hypertrophy or outcome of the study. MRI was the gold standard with also the utilization of ultrasound. So the conclusions: BFR resulted in significant greater gains in strength and hypertrophy when performed with resistance training versus that with the aerobics, such as walking or cycling. Low intensity BFR 2 to 3 times per week provides the greatest effect size compared to the 4 to 5 days per week. Significant correlations were found between the effect size for strength and development in weeks of duration, but not so much hypertrophy, meaning that there is a certain more of a time component when you ran the statistics as far as strength in relation to duration versus hypertrophy. Okay, another result of this meta-analysis is a theoretical model that looked at the timeline of adaptation for strength, hypertrophy, and neural adaptation. It's relatively a busy model with the multiple lines that you see, so we'll take a stepwise approach to it. So the low intensity BFR is in red, the traditional resistance training is in light blue. If we're looking at hypertrophy timeline adaptation, we can see that the low intensity BFR has quicker adaptation when it comes to muscle growth, whereas the traditional resistance training takes a longer time of onset. However, it has a higher potential in the long term. When we're looking at strength, we can see that the traditional resistance training not only spikes quicker, but also has a higher propensity or opportunity for increasing one's overall strength in the long term. And then finally, with the neural adaptations, we see something a little bit different here. Though the traditional resistance training has an initial impact on the neural adaptations, over the long term, due to the metabolic demands of low intensity BFR, that the neural adaptations can be greater with blood flow restriction training. And what they've shown is with the more active and athletic populations that a combination of the two is usually ideal. And low intensity BFR, at least in the rehab sector, really is indicated in those instances where an individual could not potentially otherwise partake in the high intensity or traditional resistance training due to some other medical or injury condition. Here's also a theoretical model when they looked at the effect sizes of hypertrophy and strength, still within that same meta-analysis. So you have the effect size on the y-axis and time across the x. And so you can see that there's a drastic component in regards to hypertrophy beyond that 6 to 8 week mark, whereas that strength will otherwise plateau relatively quickly after 4 weeks. Okay, here's a second study that was also a meta-analysis that was done more recently in 2016. It included 28 studies in all. The studies that you're looking at right now on this slide are specifically resistance training studies that use low intensity BFR. If we take this first figure to the left, we can see muscle strength. This is a forest plot. The red line down the middle denotes the difference or the null effect. Anything to the right of that would indicate a favor to, the study favored low intensity BFR over control, and anything to the left obviously would favor the control. The small diamond down there at the bottom indicates that the summary or aggregate effect size certainly favored the low intensity BFR relative to the control. If you turn your attention now to the right hand portion of the screen, you can see the muscle hypertrophy. Again, these are resistance training studies, low intensity BFR versus control. A little bit stronger of an effect size here, as you can see that there are greater effect sizes that are seen with some of these studies. But the aggregate effect is still the same. So the take-home message is that when it comes to resistance training studies, low-intensity BFR consistently is better than any control, regardless of whether you're looking at strength or muscle hypertrophy. Sticking with that same meta-analysis, these are aerobic trained studies, so they're either walking or cycling, etc. And the effect is pretty similar, regardless of whether you look at muscle strength or hypertrophy. For the left and the right graphs or tables respectively, you can see that the diamond at the bottom indicates that there is a positive effect size favoring the low intensity BFR in both cases. So sticking with the effectiveness of blood flow restriction training, there's 3 topics in particular that caught my interest while reviewing this topic. The first was the strength and blood flow. The second, blood flow restriction in the post-surgical populations. Third, the BFR and neurological conditions. And so there's 5 studies in all that we'll go. Starting with the effects of strength with blood flow restriction training. So this was a study that had 16 subjects that worked on unilateral plantar flexion, or the ability to raise up on their toes. There was 2 cohorts. One was at 25% and the other at 50% 1RM. And the individuals served as their own control. One calf had blood flow restriction training, the other one did not. The duration was only 4 weeks, which is half the time which is considered to be expected for strength and hypertrophy gains, which usually takes 6 to 8 weeks in traditional training. So it was done 3 times a week, 5 to 8 minutes per set. There was 3 sets to failure, and the cadence was standardized, meaning that how quickly they came up and went down on their toes. The outcomes that they looked at was using an isokinetic dynamometer, which is considered the gold standard when it comes to strength and power output. They looked at strength, max isometric contraction and force production there, as well as the power at different degrees or speeds. The blood flow pre and post, meaning the amount of blood flow that the body was actually inputting into the calf, chronically over after the 4 weeks, not within a particular session. So the outcome here we're looking at is the 1 rep max, so how much the individual could actually push in kilograms on the y-axis, and then the different training groups across the x-axis. So the 25 represents the cohorts, or the patients that were allocated to the 25% 1RM. The white block there, or bar, you can see the star representing a statistically significant difference from the normal. So you can see that there is almost like a 15% difference or increase from one to the next. And then again, these are the same subjects, just a different leg, as the one leg had the BFR, the other did not. Then if we look at 50% 1 rep max, we can see that there is also a statistical significant difference favoring the BFR group. And that was overall, it was an average of a 26% increase of the 1RM between the two groups. If we're looking at the amount of max volitional contraction, so the difference between the 1RM and the max isometric contraction is that the 1RM is how much they can actually do through a rep, whereas the force here is just isometric, meaning that there's actually no movement of the ankle. And again, significant difference, 106% increase from one group to the next when you're looking at essentially it's one leg to the other in these individuals. When you're looking at blood flow, this was quite startling for finding, in my opinion. Again, only within less than a month's time, they had a 43% increase in blood flow within the calves. So that's a relatively quick and immediate physiological change that they made within the calf muscle. And when you're considering blood flow, bringing oxygen, nutrients, etc., though these were healthy individuals, you can extrapolate that if these individuals were dealing, say, potentially with a muscle strain and or some other pathology that needed blood flow for healing rates, this could potentially be really beneficial within the rehab setting. Okay, we transition now to the post-operative patient. So looking at the table to the left, this is going to be a standard format that we use as we go through these different studies, so I want you to become familiar with it. So you have subjects and then duration, frequency, type, etc. in the first column, and the otherwise values in the second. So 20 subjects, it was over 6 weeks, again, just borderline the amount of time that is necessary to actually increase strength. The BFR training and the post-operative training started 2 weeks after the surgeries. The cohorts were a control group with the standard post-operative protocol versus the BFR group that did the post-operative protocol plus a leg press, leg extension, and kickbacks. The volume and intensity of the BFR group, when they were going through these movements, they used what is otherwise now considered a traditional model, 4 sets, 30 reps, 15, 15, 15, 30% 1RM intensity with a rest of 30 seconds between the sets, and a 1 minute rest between the exercises. And so what we're looking at now, if you turn your attention to the right portion of the screen, we can see that if you're looking at overall girth and hypertrophy, that there's a significant difference in the pre and post girth at 6 centimeters and 16 centimeters proximal to the patella tendon. So they're really looking at the girth of the thigh here, both statistically significant at the different locations for the occlusion group, but not so much for the control. Again, another significance with this point is that it's only within 6 weeks, which is a relatively short time frame for hypertrophy to actually particularly in those individuals who are post-operatively. If we're looking now at the torque, meaning the amount of force normalized to the individual's body weight, that though both groups statistically had statistical significant difference, what we can see here is when you're looking at the percent improvement involved is that there's a stark difference. There is nearly double in the percentage when you're comparing the operative limb to their non-operative limb. And same thing goes whether you're looking at the extensors, meaning the quadriceps, or the flexors of the knee, meaning the hamstrings. And so the figures here kind of tell the story. Positive, like a plus 41% in the occluded group versus the standard of care, and then the BFR again in the hamstrings had an increase of 14%. Okay, same study here. The only difference is we're looking at subjective outcomes, meaning how the patient rated themselves. In the blood flow restriction group, you can see that the asterisks there in each of the categories, meaning regardless of pain, symptoms, activities of daily living, sport, quality of life, etc., that there's statistical significant difference in the BFR group. However, not so much in the control. They did not meet statistical significant difference in their improvement in symptoms, activities of daily living, or quality of life, nor with their stair climbing ability. Transition from knee arthroscopy to ACL rehab, we will see the difference that BFR can actually have in the absence of exercise. So this is an interesting study because of that. The subjects, 16, it was a relatively small study, age 23. It was done 2 weeks, for the first 2 weeks after post-operatively, starting at day 3 post-op. The width of the cuff was 90 millimeters, the pressure 180, which was increased by 10 millimeters of mercury per day, and then it went up to a maximum on average of 238 millimeters of mercury. That was dependent on the patient's overall comfort level with it. The control group only had the cuff on, it was not inflated or additional pressure applied. The exercise, none. 2 times per day was done for the BFR group, where they did 5 bouts of 5 minutes. Sets, the rest between the sets was about 3 minutes. So if you turn your attention now to the graph there to the right, you can see that you're in the black bars is total cross-sectional area. The extensors are the gray, and the flexors are the kind of the diagonal lines. So after ACL surgery, it's typical that people will lose the girth or quad atrophy up to 20 to 30%. And you can see that in the control group, denoted by that tall gray bar, representing about 21 to 22% atrophy or loss of muscle girth. When you look now at and you compare that to the experimental group, what you can see is that the experimental group is below 10%. This is significant in the sense that the overall girth and even the when you correlate girth to muscle strength, the quadriceps strength after ACL is predicted of return to function, return to sport, as well as prognostic factor of subsequent re-injury of the ACL and the knee. And so the difference between these groups is significant, right? So the control group had 120% more atrophy percentage-wise of the extensors relative to the experimental group or the BFR group without exercise, meaning that there's actually a physiological change of cutting off the blood flow without exercise, which is significant. So here's another study. This was done over a 16-week time frame. So it started shortly thereafter the ACL surgery, and then continued beyond that time frame. So a larger study, 44 individuals, relatively even split between males and females, a little bit older population, closer to 30, 16 weeks in duration. The blood flow restriction group used 180 millimeters of occlusion. The postoperative protocol ACL was exactly the same for both groups. It was done 6 times a week. Obviously, not all those 6 times were within clinic, but the exercises were still performed. The BFR was cuffs were given to the individuals to take home. They were educated on how to properly apply it. The intensity was not specified, but it stated relatively low within the study. So if we're looking now, you see that red box within the outcome measure. So you're looking now at their overall strength And the CC represents the concentric 60 degrees per second, obviously, and then the 180 would be the same, and then the IM 60 degrees represents the isometric force that the individual could produce at 60 degrees. So these were done on an isokinetic dynamometer, right? And if you're looking here for the extensors, on average, if you took the difference between the control versus the BFR group, you can see that there is a plus increase, or plus 18% increase in the extensor force and strength relative to the other group. And that 18% is significant, particularly within the 16 weeks. Typically, people are looking to get 80% to 85% of quad, meaning that it's a quad index, so it's their involved leg over their non-involved leg. And then with the flexors, it was slightly less, but still statistically significant in all categories, with a plus 9 increase in their percentage from the uninvolved to the. Okay, this is a final study. Though it wasn't done on postoperative patients, I think it's directly applicable to that patient population. So they looked at the effects of blood flow restriction training in the presence of and in the absence of neuromuscular electrical stimulation, meaning they're actually stimulating the quad. So subjects, there were 20 of them, 29 years of age. The cohort, so they had 4 of them. So it was a control that just went through the exercises. They had the electrical stimulation group. They had the BFR plus NMES, and then they had the BFR group alone. So the durations were 6 weeks, again, relatively short time frame for strength and hypertrophy to take effect, 4 times a week. You have the cuff pressure of 200 millimeters, the width 2.8 centimeters, and then it was 3 bouts times 4 minutes. And you can see the diagram there to the right actually demonstrates how this was like broken up. So you have 0 to 4 minutes, the cuff was inflated, 4 to 8, not inflated or deflated, and it repeated itself over to the 32 minutes. So the effects here, you can see the first graph to the left looking at muscle strength, the difference in maximal strength in kilograms on the y-axis, and then the different groups there on the x. So you can see that the controls were statistically significantly different from each of the treatment groups. However, the take-home message is that the combination group, that BFR in combination with the NMES, was significant beyond the other treatments, even though there was still an effect there for strength. Then if you're looking at hypertrophy, again, relatively similar result. The control was essentially nil when it came to the amount of change in hypertrophy. However, the combination group still took home first place here, but it was not that statistically significant different from the BFR versus the NMES. So the take-home message is that BFR plus NMES is superior in regards to strength, but not necessarily in hypertrophy. All right, as we transition out of the postoperative patient demographic and more into the neurological diseases, here's a study that was a case report, which is relatively low when it comes to level of evidence. However, the crossover study design that they utilized, I think, was pretty impressive as far as the effects that it had in regards to the blood flow restriction training and the pre and post test for this patient. So it's only one individual. You can see when I say a crossover, meaning there's a phase 1 and a phase 2. One in which for the first 6 weeks they had the blood flow restriction training. The last 4 weeks they did not. They used the treadmill walking, and the time, frequency, intensity of the training stayed consistent throughout the 10 weeks. In the graph, or in the table to the right, you can see that the heart rate, the peak blood pressure, as well as the RPE did not significantly change over the 6 weeks at which they were using the blood flow restriction. All right, so here you see 2 of the outcomes: the timed up and go. How quickly can an individual stand up from a chair, walk 10 feet, turn around a cone, and come back? And obviously, the quicker you can do that, the better your function and your overall limited disability would be. So for the first 6 weeks, you can see there's a kind of a precipitous decline and improvement in the individual's speed at which they can perform the task. There was a plateau for about 2 weeks after the blood flow restriction was removed, at which time the individual regressed, getting slower with this task. With the 30 seconds sit to stand, you're standing up and sitting down in a chair without the use of arms, as many repetitions as you can do within 30 seconds. So there is a plateau effect that occurs again from week 6 to 8, at which time there's again a decline in the overall function as after the time frame in which the blood flow restriction was removed. So, all right, here we're looking at 2 other outcomes. The 6-minute walk test, which there's a ton of research utilizing the distances you can walk within 6 minutes, as well as your overall functional ability, your risk of falls, your risk of even death has been predicted with this. And you can see that from week 0 to 6, there's a precipitous increase, a plateau at weeks between 4 and 6, and then there's a drop off after the blood flow restriction training has been discontinued. With the RLS scale, this is Restless Leg Syndrome Questionnaire, which asks an individual about the symptoms of restless leg syndrome. Less score or lower score represents a reduction in their symptoms. And from week 0 to 6, again, there's a precipitous improvement, a plateau for about 2 weeks, and then a regression from weeks 8 to 10. Okay, so though that was only a case report, I think it really shows the promise of what blood flow restriction training may have in the neurological population. And so I expect that there will be additional research to come on that. So the last point that I want to talk about with the effectiveness of BFR is the bone remodeling. So here's 4 studies that were utilized to look at the positive bone markers when it came to blood flow restriction training. These were collected within a systematic review that came out just this year in 2018. And though they're relatively small studies, you can see that the conclusions that they came to consistently showed positive markers and indications that blood flow restriction training also improves bone remodeling. And so the conclusions that the authors came to was that there was a decent amount of heterogeneity between the designs of these studies, as well as the standardization of frequency, duration, and intensity of training. So you can't necessarily hang your hat on it, but I think that this systematic review really points to the fact that there needs to be more research and to be done when it comes to BFR and the effects that it has on bone remodeling. When you're looking to the future of additional studies, so currently if you're looking at the clinicaltrials.gov, you can see that there's current studies being done in the lower extremity for knee arthroscopy, ACL, femur fractures, Achilles tendinopathies, meniscus repairs. In the upper extremities, distal radial fractures, rehab, rotator cuff repairs, and just more general joint arthroplasty, nerve injuries, and muscle strains are also being done. Additionally, other patient demographics that potentially may show benefit with this is the myositis individuals, astronauts. So when gravity is otherwise reduced and they go through significant detraining, and typically, there's been reports where they have to actually be carried out of the shuttles after time and space due to the lack of gravity and the detraining effect that the body undergoes, the geriatric population, as well as adolescents. And I will say that the volume of research is rapidly expanding within this field. Okay, so now transitioning to the mechanisms of blood flow restriction. So there's 2 primary factors when it comes to the stimulus of the physiological changes that blood flow restriction training has. The first is mechanical tension, the other is metabolic stress. So mechanical tension leads to hypertrophy via the following steps: mechanotransduction, increase in localized hormone production, muscle damage, reactive oxygen species or ROS production, and then increase fast twitch muscle fiber recruitment. Now, metabolic stress, on the other hand, leads to hypertrophy via increased systemic hormone production, increased fast twitch fiber recruitment, cell swelling, muscle damage, and again, increase in ROS production. Now, these two primary factors are present in really any regards of resistance training. And it's never one or the other, it's a combination of two that leads to the muscle hypertrophy stimulus. So when we're comparing the blood flow restriction training stimulus and response to that of traditional resistance training, we can see that there's a different balance as far as how much mechanical tension and or how much metabolic stress contributes to the hypertrophy. So this slide kind of lays that out really nicely. So in the top left corner, you can see the high intensity resistance training is high mechanical tension with relatively low metabolic stress. Due to the intensity of the lift, you do less volume. However, on the other end of the spectrum, you have the low intensity blood flow restriction training has high metabolic demand with low mechanical tension. So these are the primary stimuli that then lead to the secondary mechanisms that you can see in the white box here. And so the secondary mechanisms, we'll kind of step through them one at a time. The fiber recruitment is also increased with both, regardless if it's a high mechanical tension or a high metabolic stress. The mechanical transduction is increased with more mechanical tension, decreased with metabolic stress. Muscle damage, similar. So the higher the mechanical tension within the muscle, the greater damage there are to the muscle cells that then rebuild, come back stronger than they previously were. However, with the metabolic stress alone, the muscle damage isn't as great. Systemic and localized hormone production is increased in both. The cell swelling only occurs in the metabolic stress with blood flow restriction training, as there's actually an increase or swelling of the muscle cells themselves, which is different than what you might otherwise think of. Okay, we're trapping fluid within the lower extremities or the upper extremities, what have you, and thus it makes sense that there's the cells or the swelling. However, that swelling remains even after the restriction has been let off and the blood continues to flow as normal. So it's a secondary mechanism than just the fluid pooling, if you will. The reactive oxygen species increase in both. There's some question as to how much it increases with the metabolic stress. NOS is nitrogen oxide synthase, which is an enzyme that is responsible for increasing nitrogen oxide during activity and exercise. The heat shock proteins are proteins that essentially protect the human body and the cells within the muscle during those periods of increased metabolic demand. And so you can see kind of the cascade and the comparing contrasting between the mechanical and the metabolic stress, both of which will lead to autocrine and paracrine actions. Autocrine is where a cell is releasing a signal, and then then that signal is then reacting directly on that individual cell, whereas the paracrine is the cell is sending off a signal that is then signaling to adjacent cells, both of which then lead to the hypertrophy response. Okay, the next component that I want to talk about specifically is the fiber recruitment, because this is a critical and fundamental principle when it comes to hypertrophy training. The blood flow restriction plus exercise leads to a decrease in oxygen, which leads to a decrease in the force production of that muscle. Obviously, muscles need oxygen in order to contract. However, because of that decrease in ability to produce the force, there's progressive recruitment of additional motor units, which may take place to compensate for that reduced force production. Thus, the increase in muscle unit firing rates and muscle unit spike amplitude is associated with arterial occlusion, suggesting that the recruitment of high threshold motor units or fast twitch fibers, which were only really classically thought to be recruited in the instance of high force production or high intensity lifts, can also be preferentially recruited in the absence of available oxygen. Hence, in the presence of blood flow restriction, when oxygen is somewhat depleted or less within the muscle, then the higher motor units, which have a higher propensity of hypertrophy, will thus be recruited. Here's a specific example of that. So this study looked at males between 25 and 40 years of age. They looked at a simple exercise such as the bicep curl at two different intensities, 40%, 80%, and 1 RM. The occlusion was done at 0, so no BFR, 50 and 100 millimeters of mercury. The type of occlusion, meaning the type of cuff, was pneumatic, and then the cuff width was 90 millimeters. So the integrated electromyography, or EMG, is essentially the neural input that's going into the muscle. So this study shows that demonstrates no difference in the EMG activity between the low intensity occlusion and the high intensity non-occlusion states, suggesting that because the EMG did not statistically significantly differ, thus the motor unit recruitment would be sufficient and relatively the same between the high intensity BFR, the high intensity lift and the low intensity BFR. And that's exactly what the graph to the right is showing. So you have the EMG activity, how much of neural input is going into the muscle. You have the 0, 50, and 100 occlusion pressures there on the x-axis. And what you can see is that in the presence of no occlusion, that there's a significant difference between the groups, between the instance in which the individual is lifting 80% 1 RM and 40%. However, as the occlusion pressure increases and the oxygen supply decreases, then there's more of a balance, thus a higher recruitment of the motor units with the occlusion pressure, despite still having a low intensity of 1 RM. So this is simply an example of proving that hypothesis of the fiber recruitment model with blood flow restriction. All right, let's talk about safety and side effects. Obviously, when you're occluding blood, there are some concerns and some precautions that need to be taken into account. All right, so when considering safety and side effects, it's important to consider the most common side effects that occur with this type of training. So this was a study that sent out a survey to individuals who were certified in CATSU training. It included 232 facilities, over 12,000 subjects. It occurred in 2016. There was a uneven distribution with more females than males as far as the subjects are concerned. If we turn our attention to the graph, you can see on the y-axis there's the different symptoms. Across the top x-axis are the number of facilities, meaning like the prevalence of these side effects that were reported. What we can see is that subcutaneous hemorrhaging was among the top, as well as anemic symptoms. So let's break those down. So anemic symptoms such as lightheadedness, fatigue, dizziness, perfusion, etc. So those may be otherwise considered symptoms that would be experienced with high intensity resistance training in general. So it's not surprising that they were also present in the presence of low intensity BFR. So subcutaneous hemorrhaging is a very fancy way of saying that they were bruising, or that you had colored marks underneath the cuffs, particularly more in the upper extremities than the lower extremities. This was followed by drowsiness, as well as temporary or transient numbness within the limbs, which obviously can happen. Again, it's only temporary during the period of training. So these are the most common. Let's look at some of the more rare adverse events that were reported. So this was a second study that did a similar thing, that sent out a survey to CATSU trainers in Japan, over 106 facilities. These authors also included the subjects within their own clinic, which over about a 5-year span included over 3,500 subjects. So there was one individual who unfortunately had a brain hemorrhage during their blood flow restriction training. The author's comments to this was is comparable to a sudden death event within any athletic participation. So again, if you're looking at, even here in the United States, if you're looking at the NCAA records as far as sudden death occurrences, though this is dropping with more awareness and screening that has been done, it is potentially a risk whenever undertaking physical activity and exerting the body. So if you're looking at the different cohorts here, so individuals under 35 years of age should, the most common kinds of sudden death would become by hypertrophic cardiomyopathy, meaning an enlarged heart, cardiomegaly, coronary artery malformation, aortic rupture, brain hemorrhaging. It's very difficult to obviously capture these underlying and non-symptomatic conditions without proper screening. Individuals over 35 years of age, 80% of them will either suffer an immediate onset of death with either brain hemorrhaging and or coronary artery disease, also known as cardiovascular disease here in the States, which is currently the leading cause of death. In general, not sudden in this case, right? So venous thrombus or thrombosis is another one. There's a prevalence of this. However, it is important to note that due to the physiological responses that blood flow restriction training has, that this actually creates a fibrinolytic state, meaning that this aids in the restricting the formation of thrombi. And then the authors also went on to look at the prevalence rates of deep vein thrombosis in healthy individuals, which is 1 to 3 in 10,000, pregnancy 3 to 11 in 10,000, and even postpartum even higher at 30 to 40 per 10,000. So if you're looking at the aggregate number of subjects between this study and the combined last one, that the prevalence of deep vein thrombosis is below any of these demographics. The transient numbness we talked about in the last slide, the prevalence wasn't specifically reported. There's been no papers that I could find on it, and the numbness, when it's considered a rare adverse event, actually can last beyond the day of training and a couple days later, where it spontaneously resolves. Rhabdomyolysis, there was one incidence of this. This was considered a surprise in the sense that, as we talked about with the mechanisms, that there's a very little amount of muscle breakdown and damage that actually occurs in low intensity blood flow restriction due to the low mechanical tension. However, risk factors that may predispose someone to developing rhabdomyolysis, even in the state of having low mechanical tension through the muscle, is poor hydration, heat and humidity environments. Venous injury and induration is another potential risk factor. The prevalence was not reported. It really most commonly affected females 30 to 50 years of age, spontaneous resolution within 1 to 2 months post treatment of KATSU training. Which is, again, in our terms, synonymous with the BFR. Repeat pressurization and depressurization can actually help these individuals for their blood vessels to accommodate to the training type. If the individual is sedentary in general prior to the training, it's important that additional precaution be taken up with this individual, as their system is not only not exposed to regular fluctuations in their arterial and their venous blood flow, but then particularly when you start to clamp off the system and puts additional stress on the system, that their bodies may not adapt as readily, leading to the potential venous induration. Also, it's important to adhere to the KATSU training principles. Obviously, a specific time frame and intensity of pressure appropriate for the limb and the individual will be important in helping to reduce the venous induration and or injury. Okay, so how do we go about screening people properly when using blood flow restriction and or KATSU training? So the PAR-Q should be a standard measurement or handout that is given within a clinic, unless obviously there's medical background that is already captured by either the EMR system or by the referral, etc. And so the physical activity questionnaire really is a questionnaire that is relatively simple and straightforward to fill out. It takes 5 to 10 minutes, where they're simply screening the individual to reduce the risk of any adverse events, particularly with the cardiovascular and or pulmonary system. The Part Q Plus takes into obviously a little bit more history taking that gets into even joint and arthritic issues, whereas the Part Q and U, done in 2017, most recently updated, is again more for the cardiovascular. They talk about angina symptoms like chest pain, shortness of breath, etc. Okay, so here's a screening intake that is recommended by the literature. So you can see that there's 6 categories there in the first column, the criteria in the middle, and then if the criteria is thus present, the indicated actions that should be taken by the practitioner. So let's talk about symptoms. So again, this gets to the Part Q. So any chest pain, discomfort, palpitations, shortness of breath, dizziness, fainting, intermittent claudication, etc. In that case, if one of those is present, you would then do an exercise tolerance test. So this slide is predominantly just for your reference. I'm not going to go through it in exhaustion. However, the things that I do want to briefly point out is that besides for the exercise tolerance test that the therapist or the healthcare provider should be addressing is assessing severity of selected criteria, particularly when it comes to lifestyle disorders or non-communicable diseases, as well as the lifestyle guidance in regards to the sedentary lifestyle, smoking, and alcohol. So take a moment, look at the lifestyle disorders: high blood pressure, diabetes, hyperlipidemia, and obesity. So when we're talking about assessing the severity, that comes to the next, where we're looking at the criteria. So the indicated groups or ranges, the precaution ranges, and obviously the contraindications. So with the high blood pressure, again, 140 to 160 systolic, 90 to 95 diastolic would be indicated for BFR. That would be okay. And then precautions would go up. The higher the systolic, the higher the diastolic. Again, kind of a reference slide. I don't want to go into the details, but it's here for your review. So should you be using CATSU and or blood flow restriction training within your clinic, you would be able to properly screen and identify their severity and whether they would have precautions, indications, or therefore contraindications based off these metrics. Okay, so I thought it was also interesting to look at how well the current healthcare system is screening these individuals when applying blood flow restriction training, and because it's only been about a decade or so that's been here in the States, we know that usually research lags behind clinical practice. So we have to turn to the Japanese literature and looking at what they have come up with. So you've seen this study before. This was the one where they sent out the survey in 2016. So looking at the prevalence rates here. So the checklist. This is the checklist that is otherwise considered to be standard with CATSU training of each of the metrics that should be taken upon initiating the first training. However, what you can see is that not many of these are followed. Right. So the top 3, heart rate or pulse rate, right, blood pressure, and the interview of the subject, those are the only 3 where more than half of the facilities that reported actually performed this. Body weight, body composition were the next 2 to follow, and after that things just kind of drop off as far as the prevalence of how often they're checked before the initial session. Again, these are the recommended screening intake measurements that could and potentially should be taken prior to undergoing BFR and or CATSU training. Okay, in subsequent training sessions, this is the checklist that providers should be doing. Again, similar story here, that Those top three: interview, blood pressure, and heart rate. After that, things precipitously drop off as far as the prevalence at which they're being screened. The only one that is high, the fourth place there is the rating of perceived exertion, meaning asking the patient on a scale of 0 to 10 or 6 to 20, depending on which scale you're using, how hard they're actually working. Frequency of testing. So this is quite interesting, right? So how often are these tests being done when people are coming in for subsequent tests of CAT-SU training? So the most often response was once a month. So I would say that I would argue that at least once a week would probably be important to be checking in on these individuals, for the instance that their hemodynamics not only can change from a moment to moment, but certainly over weeks, from one week to the next, even particularly in the setting of physical activity, such as like low intensity BFR and whatever else they may be doing within their regimen. Okay, so this is something that I modified from one of the studies, but modifying it in such a way that I thought it could be a clinical applicable tool for you in order to be able to quickly stratify someone's risk when performing BFR. So you have the point system across the top. So points 1 through 5. You have the criteria that classifies each of those points. Okay, and so then the next row that you see is column score. So essentially you go through, check off all the indicated boxes based off the individual that you're working with. You add up the column score, and then you add up the entire score, which is all of the columns, into that final box. And then the interpretation there, you can see I color coded it between low to high risk. Obviously less than 1 or equal to 1 is a low risk. Mild risk is at 2. The moderate risk at 3, and then 4 to 5, you really got to be questioning what is the risk to the benefit of doing a BFR with these patient populations. What is interesting is even in the presence of AFib or heart rate, that it's considered to be a moderate risk. I would certainly question putting blood flow restriction on an individual in the setting of an arrhythmia, for there's certainly an increase in demand on the heart during training. But again, here's for your reference. Use it at your discretion. Yeah. So another way that you may go about, so for those of you who are more into algorithms and more a little bit black and white in the presence of what may be a gray decision. All right, so does the individual have any contraindications for BFR? If yes, consult a physician. If BFR is approved by the physician, then you can go ahead and go to the next step, which is the individual mobile? If no, apply moderate BFR alone to the limbs. An example would be the ACL study that we looked at previously, where they had a preservation of their quadriceps and hamstring muscles after surgery. Next, so if the individual is mobile, could the individual tolerate lows 20 to 40% 1RM? If yes, then go ahead and combine low resistance training with BFR. If no, combine low workload cycling and walking as an initiation to improve their tolerance. If they can tolerate the 20 to 40%, it may be of benefit to, as I mentioned previously, combine traditional high load resistance with the low load BFR within a structured periodization training, so that you can reap the benefits of both the high mechanical tension of the high intensity as well as the high metabolic demand of the low intensity BFR. Okay, so essentially the summary. So here's a good summary statement by Lenicky. Again, he's out of the University of Oklahoma. In conclusion, the current research on blood flow restriction training with respect to safety outcomes confirms early reports that blood flow restriction exercise, when used in a controlled environment by trained personnel, is a safe alternative for most individuals, regardless of age and training. And he uses the word alternative there because, again, the evidence is strongest for those individuals who cannot otherwise tolerate a high intensity load at the time of undertaking BFR. Here's an example of just kind of reassuring Lonicki's statement there. So this was the only study that has been done. It was a pilot study that was done with individuals with hypertension. And so it really kind of looked at essentially how their hemodynamics, or how their body responded to a restriction in their blood flow despite already having resting hypertension. It didn't. I wasn't able to identify the level of their hypertension was a level 2, level 3. I wasn't able to gain that from the article. But what is the point that I want to make with this is really essentially how low intensity BFR correlates to the blood pressure and the hemodynamics of individuals with hypertension who are undertaking high intensity training. So a large percentage of the U.S. population currently is considered to be hypertensive and or on blood pressure medication, and a large percentage of those, I don't have specific stats, but I would argue that they're undergoing high intensity training given the prevalence that is currently within the fitness industry. All right, so these individuals did knee extension exercises, so it's shown there to the right. 3 times 10, 1 minute rest in between. The blood flow restriction group did 20% 1 RM. The strength group did 65% 1 RM, and the control did nada. And so I think it's important to say that this is not a study in which they allocated individuals to a particular cohort, but rather they had the individuals come in 3 times. Each time they were randomized either into the control, the BFR, or the strength group. And so there was actually a sense of a slightly crossover effect that was occurring within the data. So let us go ahead and compare. So if you're looking at the systolic blood pressure, which is on the y-axis, and across the x-axis you have this set 1, set 2, set 3, as well as the rests in between, you can see that the blood flow restriction training followed right in line with that of the relatively high intensity, or 65% 1 RM strength scenario. Diastolic training. So the diastolic training was also consistent with that of the high intensity training. And then when you're looking at our overall cardiac output, there was an actual dip within the cardiac output relative to the high intensity group, suggesting that given the one pilot study that has been done with BFR in the setting of hypertension, that it is indeed safe for cardiac output as well as the blood pressure. Okay, so let's get to the good stuff, the practical and clinical applications. So again, taking from that survey study, we're looking at the age demographics here of the number of the subjects that were included from the different facilities. So the common exercise modes that are done are body weight, barbell, and machines are the top 3. This was done predominantly once a week or twice a week. 1 to 3 times per month was the third most often. As we've established with the previous meta-analysis, that 2 to 3 times per week is sufficient and optimal, more so than even 4 to 5 times a week of BFR. Here you can see that only a small percentage of the facilities were actually using it for during the optimal frequency. So exercise duration, so the highest is between 20 and 50 minutes. Depending on the upper or lower extremities, the recommendations vary. So the upper extremities are typically between 15 and 20 minutes, whereas the lower extremities can be a little bit longer. But again, the 40 to 50 minute time frame, though it's the third highest on this list, is considered to be outside the range of what is considered normal for blood flow restriction guidelines, as well as KATSU training. So the purpose of this slide, you've seen this information before. This was done from the meta-analysis from Lenicky in 2014. Really what I want to drive home is, okay, so maybe there's heterogeneity with clinical practice, but gosh, there's also a lot of heterogeneity within the research. And so you can see from the protocols here that there's not much standardization, but a large distribution as far as not only the resistance training versus the aerobic, but also within both of those different categories. So let us see, in the presence of heterogeneity within the clinical as well as the research, where can we be guided? So there was done by Scott et al. In 2014 that actually summarized the current best practices to date of blood flow restriction training. So it should be the application should be approximately around the limb to be trained. The width of the cuff is dependent on whether it's upper or lower extremities. The occlusion pressures also will differ between 50 and 80%. It is important that you specify that to the limb in question. So if you, for instance, if you take the brachial pressure of the upper extremity and then apply that like 80% of what would otherwise occlude that to the lower extremity, that doesn't really have strong correlation. You would potentially need to guesstimate the amount of arterial pressure going through the femoral artery of the leg. And so we'll get more into the specifics of that and how you clinically can actually guesstimate. So occlusion pressures, so BFR alone attenuated, decreased in muscle mass and strength, meaning that there is only BFR, no exercise involved. And what we can see is that a consistent finding from what we previously showed in the past slides is low load resistance training plus BFR is substantial in increasing muscle mass and strength. Okay, so that last slide again gave you specifications on the cuff application. This gives you more so on the specific parameters of the exercises that you're doing with this. So single multi-joint resistance as well as aerobic and or aerobic exercises are appropriate with BFR. The load with the exercise is 20 to 40%. Anything higher than that has yet to prove to be of further benefit. However, we know that from the hemodynamics and the safety standpoint that doing high intensity resistance training in the presence of BFR may not be recommended. As far as volume or the number of repetitions, sets and reps, so 50 to 80 repetitions. The standard scheme is usually 30, 15, 15, 15, as you previously saw in the methods of the ACLs and the arthroscopy study. Rest intervals, 30 to 45 seconds. Clinical populations, 2 to 3 times per week is sufficient. For athletic populations, potentially a little bit more higher frequency depending on their current periodization of training and where they are in their season. A quick note on the rest is that though Scott et al. In 2014 did note 30 to 60 seconds there for the 30 to 45 seconds. Other studies and other researchers have said that you can tailor the rest intervals to the actual hormonal response that you would like to get. For instance, if you do want more of an anabolic hormone, growth hormone, testosterone, shorten the time frame versus if you're looking for insulin-like 6 concentrations for whatever reason, right? Longer duration may actually be better for increasing those concentrations of hormones post-exercise. Between training sets, BFR should be continued throughout. That's quite important. As far as the duration or overall time, as we saw from Lenicky in 2012, that 6 to 10 weeks is sufficient and adequate for higher gains when it comes to hypertrophy. Okay, so when we talk about looking at the cuff application, so Lenicky also provided guidance in a study that looks at 60% complete arterial occlusion, which has been a pressure that has been sufficient for giving the strength and hypertrophy responses as well as maximizing EMG activity. So that should be sufficient, that you can actually predict the amount of occlusion pressure based off the circumference measurement of the individual's resting thigh. So they went 33% or a third of the way down the thigh from the distance between the patella and the in the groin, and they took a circumference measurement. Based off that, you can then surmise the amount of pressure that the cuff should be in order to get to 60% arterial occlusion pressure. Factors additionally besides for circumference that should be consider the width of the cuff, the circumference of the limb, and the arterial occlusion pressure of the limb. So it may, if possible, you should have a guesstimate or an actual measurement of how much pressure is going to actually occlude the entirety of arterial blood flow. Obviously, you know quite quickly if this occurred, given the response from the patient with the limb potentially changing color and or paresthesias relatively quickly. So talking about the types of cuffs, so this is a big question. There's many models that have kind of jumped on the bandwagon and kind of come out with their own form of this. So you have tourniquet, inflatable cuffs, elastic knee wraps have even been used. What has been shown is that even with the narrow nylon cuffs, you can get the same similar amount of pressure with elastic cuffs that are 5 centimeters at 50 millimeters of mercury. And that's consistent both at rest and with exercise. So the widths of the arms are important as far as the bands, and this is really because the width of the cuff have shown to be tapered, or the hypertrophy of the muscle is to be tapered directly below where the cuff is actually applied. So cuffs of 13.5 centimeters within the upper extremities is suboptimal because you're not going to get as much of the bicep and the triceps within the hypertrophy range. Again, the legs are the wider cuffs. The wider cuffs may actually provide a greater occlusion than the narrow cuffs at the same amount of pressure. So there was one clinical question that was asked by a colleague as far as potentially doing this within the clinic and using TheraBands as a means of trying to get to adequate blood flow restriction. So let's take the black band for example, right? So this is the one that's the form of band that is most commonly seen in at least the clinical settings that I've worked at. So at 150% of tension, this TheraBand has approximately 12.3 pounds of force or tension. The next thing you would need to do is to actually take the circumference measurement of the individual, say 50 centimeters. And then if you look at the overall surface area of the band, which would be important for looking at the overall compressive force around the limb, 50 centimeters times 14 centimeters, right, to get your surface area of the band, because the TheraBands these days are standardized at 14 centimeters approximately. The TheraBand tension, so you have to convert to kilograms to make everything metric. If you divide that by the surface area of the band, that would get you to this somewhat arbitrary figure of kilograms per centimeter squared. And then you would need to convert the kilograms per centimeter squared to millimeters of mercury, which if we're for a 50 centimeter circumference limb, 120 millimeters, according to Lenicky, would be sufficient for getting 60% occlusion, which would be adequate for hypertrophy stimulus. The target pressure then divided by the TheraBand pressure, meaning that if you had a black band, you would need to provide 150% tension 20 times around the limb in order to occlude to 120 millimeters of mercury. Now that being said, so theoretically, yes, it's doable. Yes, it would take a sufficient amount of TheraBand, right? So 50 centimeters times 20, or maybe like 75% of that, or like so times 15, would be relatively a lot of TheraBand. And so the other thing that should legislation, right? So BFR training and the scope of practice, though the APTA says BFRT is part of the professional scope of practice for the physical therapists, they say that it's important to check state legislation and the Practice Act. Given the nuance of BFR, right, so it may be silent within the legislation, as not only does research lag behind clinical practice, but certainly so does legislation at times. And so if it's not in the Practice Act of your state, then checking the state laws to confirm, and then the CAPTA Practice Act, that is of California, is silent on BFR, but there are no laws currently prohibiting BFRT from being performed within the state of California. Keep in mind that TheraBand example that we gave now to the FDA regulations. So pneumatic tourniquets are a Class 1 FDA regulated product. Ensuring that the product is registered and approved by the FDA when practicing within the United States is critical to potentially prevent from lawsuit and other malpractice, if you will. So if you were to provide a TheraBand for mild blood flow restriction, you do well within your documentation to say that you're doing it for other reasons, potentially soft tissue with the friction massage, etc., as the patient actually goes through physical exercise with the band. Additionally, when it comes to billing for this, so you bill under the standard the physical therapy codes if you're obviously a physical therapist, and that would be whatever the exercise was or whatever the intent of the exercise or intervention was when the individual is using the cuff. For example, if you use BFR in the combination of NMES for an individual postoperatively and you're contracting their quads, the billing would then obviously be potentially neuro-re-ed, versus if you actually have someone doing squats and lunges and step-ups with BFR cuff, then you could bill therapeutic activities and or therapeutic exercise depending, etc. So there's no specific billing code for BFR. Also sticking with the clinical applications, so one thing that should be considered is how is your patient going to actually tolerate and perceive their exertion when utilizing BFR. So you can see with this study that there is a consistent trend between BFRT and high intensity training that over time, approximately 6 sessions, you can expect that the average rating of perceived exertion will drop approximately 20 to 40%. So again, their body does begin to accommodate, and their exertion or perceived exertion will also drop over time. Okay, and lastly, this is a study that I included from the standpoint that I really think it's important that you understand what is going to happen to the cardiovascular system of your patient, assuming that they are not hypertensive while you bring them through physical exercise and exertion with BFR. We have a general sense from the resistance training examples that we've provided that the systolic, the diastolic, as well as the cardiac output will be in safe limits. However, I like this study because it actually stresses the cardiovascular system in the presence of blood flow restriction. And so you have 3 groups. You have a low intensity group, you have a BFR low intensity group, and you have a high intensity group. And essentially what they did is they tracked a number of hemodynamic measurements throughout a 30-minute ride. Intervals. So here's the systolic blood pressure. So denoted in red is the BFR group, the low intensity group, and then below that are the black dots showing the low intensity group without BFR, and then you have the gray dots above showing the high intensity group. And what you can see is that the systolic blood pressure is below the high intensity group in at all stages, whether it be rest and or during the intervals, and with progressive intervals at that. When you're looking at the diastolic pressure here, you can see that there is a difference, a stark difference between the BFR low intensity group and the high intensity group. And that is a progressive increase in the diastolic over each interval and over time. Now, when you apply that to the mean arterial pressure, which is like an average of the blood pressure between the systolic and the systolic and the diastolic, you can see that a similar trend occurs. And so with subsequent intervals with BFRT of low intensity of 40% VO2, you can see that there's a gradual increase and ramp up in the mean arterial pressure. However, if you're actually looking at the millimeters of mercury, you can see that the mean arterial pressure is not that high. is 125. So it should be noted that BFRT for cardiovascular training with 40% VO2 max, so a relatively low intensity, can increase mean arterial pressure with low BFR. Okay, so this should be taken into account for your screening, right? So you should screen accordingly if you're going to do BFR in the presence of someone who has hypertension at rest or at baseline, because of this potential increase that can occur with the mean arterial pressure with exertion. So conclusion and summary, I simply want to wrap this up and the take-home points. So here's a nice summary. These are summary points also from one of the meta-analyses that we saw from 2016 from Slees. So the first, low intensity blood flow restriction may increase muscle strength and size. Used when traditional high intensity may be inappropriate or unattainable, such as a rehab setting. Quantifiable muscular adaptations can present quickly within 6 weeks or so, offer greater returns in strength within that time frame. BFR training has applicability to a range of populations who may seek to progress strength while reducing loads on the associative tissue, such as muscle, tendon, connective tissue, and bone. Early studies indicate that BFR may have positive effects on bone remodeling. That last point was not summarized by the meta-analysis previously mentioned. However, it was the conclusive statement done within the systematic review that looked at blood flow and bone metrics. Again, so a reminder between the primary and the secondary mechanisms that make BFR adaptations plausible. The side effect, the safety and side effects. So follow these 12 basic principles in order to guide your patients to safe training with blood flow restriction. Confirm no contraindications. Hemodynamically unstable patients, i.e. heart rate that is tachycardic at rest or somewhat elevated, blood flow, blood pressure, systolic and or diastolic within a hypertensive range should be considered a precaution, if not a contraindication. Previously, individuals who had a thrombus or DVTs should be contraindicated. Explain the subcutaneous hemorrhaging, i.e. the bruising that can occur, particularly with the upper extremities versus the lower extremities for whatever reason. Individualized training for that individual. This goes for any modality and any intervention. Build relationships of trust with the patient. Pay attention to fainting, dizziness, lightheadedness. This is a standard of practice regardless of the intervention at hand. Using caution with older individuals, those who are bedridden, postoperative patients with DVT. Always have an AED available, obviously, really whenever anyone's exerting themselves, particularly when you begin to occlude blood flow. Short-term and long-term, short-term with low intensity loads is optimal and safe. Contraindications is if the person is not feeling well, perhaps it's not the best day for a BFR. If unsure about medical conditions, speak specialist consult. Again, you also have the risk stratification tool that I put together for you, as well as the algorithmic decision-making tree, as well as like the overall screening intake that is used as standard of practice within KATSU training, even though it is maybe not common practice. These again are review slides that are simply for your reference, so that you can give your patients the highest quality of care when performing restriction, when it comes to the cuff pressure, the cuff use, the volume of exercise, the frequency, etc. Okay. If there's any comments, questions, feedback, discussion, by all means, please feel free to type them in the box below. I'll respond to them as they come. Additionally, I'll flip this now, so that, if you like, pull the reference. You need to learn detail about something that is currently a blood flow restriction of the study. Your interest. Continue to